Hi, my name is Cherian from Maryville University, doing my DNP program. And as part of my project, this is my oral presentation on my title, which is uh, Obesity Implementing Lifestyle Modification with Anti-Obesity Medications. And my question of inquiry is the clinical inquiry question of this project is how in an adult patients with obesity does the combination of GLP-1 receptor agonist and structured lifestyle modification compared to lifestyle modification alone lead to greater weight reduction and improved clinical outcomes in primary care setting. And for this, I would really want to thank all the people that supported me from my clinic, and especially Dr. Jennifer Theo, chair for this project, and Dr. Sierra Moore, second reader, Dr. Ajaz Khan, my community member from my clinic, and all the other staff members and the patients who really supported me in this program. Uh, the In the introduction, I would like to say that obesity is a chronic multifactorial disease that negatively impacts health and quality of life. Although dietary modification and enhanced physical activities are typically the initial treatment option, their success is restricted by various physiological, environmental, and behavioral obstacles. In recent years, anti-obesity medication, especially GLP-1s, have demonstrated significant clinical benefit when paired with structural lifestyle modifications. When many patients come to me, they ask me like, what, why don't I do only the lifestyle modification by itself and do gain weight reduction? But sometimes it's kind of little harder to achieve the goal which with one modification by itself alone. And it has shown that several of that later on in this slides, I will prove it that many people who, along with the lifestyle modification and GLP-1s, have gained a greater success than by doing it alone. This chapter explores current evidences on integrating AOMs, which is anti-obesity management, with behavioral counseling strategies in adults with obesity across various clinical settings. The background is obesity has emerged as one of the most pressing public health challenges worldwide, according to the Centers for Disease Control and Prevention, CDC. More than 40% of adults in the United States are currently classified as obese, highlighting the widespread nature of this condition and its implications for healthcare systems. Obesity is associated with significantly increased risk of chronic diseases such as hypertension, cardiovascular disease, type 2 diabetes, metabolic syndrome, and certain forms of cancer. Additionally, obesity can negatively affect quality of life by impairing mobility, sleep patterns, and psychological well-being, according to WHO 2024. The United States Preventive Services Task Force, USPSTF, recommends that clinicians screen adults for obesity and offer or refer the individual with a BMI of 30 or more kilograms per m2 square or higher to intensive behavior interventions. Recent advancements in pharmacological therapies have transformed the landscape of obesity treatment. Second-generation anti-obesity medications, including the GLP-1s, such as semaglutide and tirzepatide, have demonstrated substantial efficacy in promoting weight loss when combined with lifestyle modification interventions. Although obesity was frequently documented, a standardized protocol for lifestyle counseling, behavioral support, and evaluation for pharmacologic therapy was not consistently implemented. This gap contributed to missed opportunity for early intervention and comprehensive obesity management. Addressing this gap by implementing an evidence-based obesity management protocol can improve patient outcomes, enhance patient education, support sustainable lifestyle modification, excuse me. This DNP project was developed to implement and enhance, evaluate a structured approach to obesity screening and management in a clinical practice setting. So there was a lot of articles, a lot of research went throughout the before and after the project through the several medias. And this was a comprehensive literature search was conducted using Maryville University Discovery Tool and Ovid synthesis platform. These databases include Medline, CINAL, NAHL, and Science Direct. The research focused on peer-reviewed English language articles published between 2018 and 2024, emphasizing adult patients treating for obesity in clinical or primary care environments. Search terms included obesity, GLP-1s, semaglutide, tirzepatide, anti-obesity medications, lifestyle modifications, behavioral counseling, primary care, Boolean operators, and or not were applied to refine results. From an initial pool of 134 articles, 23 full text articles were reviewed, and out of that, 10 were selected based on relevance, methodological rigor, and clinical applicability. Literature review. The 10 selected peer-review articles were grouped into 4 key themes: incidence of risk factors, screening tools, barriers, and interventions. Incidence of risk factors were like obesity is associated with variety of behavioral, genetic, environmental, psychosocial risk factors. Individuals from low-income or marginalized communities face higher risk due to food insecurity, limited access to physical activities, and reduced healthcare utilization. Emotional eating, chronic stress, cultural weight loss, and comorbidities such as the hypertension, diabetes, or sleep apnea were one of the other ones was the risk factors. This finding suggested that multifactorial obesity drivers must be addressed through comprehensive and patient-centered care plans. Screening tools were used like BMI, body mass index, historically served as the main instrument for identifying the obesity. Edmonton Obesity Staging System, EOSS, assessment obesity severity based on functional status and comorbid conditions. 3-factor eating questionnaire, TFEQ, were used, and these were the tools, screening tools that were used to evaluate the patients. Barriers, time constraints, insufficient provider training, low reimbursement rates, and lack of care pathways were some of the barriers that we were facing. Coming to the interventions. In clinical studies, GLP-1 receptor agonists like the semaglutide, tirzepatide have shown considerable weight loss advantages. Recent reports have reported up to 20% average body weight reduction with the tirzepatide and semaglutide. These medications were more effective when paired with structured lifestyle counseling or modifications. Theoretical framework. So this was the framework that we designed from the week 1 to the week 10th. Week 1, it started with preparation, finalizing screening tools and protocols, train staff on the new obesity management process, collect baseline data on patients with BMI greater than or equal to 30 kg per m squared. In week 2, start screening, implement the screening process for eligible patients, provide educational materials on the obesity, schedule follow-ups for high-risk patients. In week 3 to 6, core interventions, dietary counseling, start personalized nutrition plans, introduce tracking tools, example, food, dairies, apps, physical activity plans, create individualized exercise plans, share local resources, encourage activity tracking, behavioral support like conduct counseling sections focused on behavioral changes, and mental health screening, refer as needed. Medical options like discuss and prescribe anti-obesity medication for eligible patients, monitor patient progress and side effects. In week 7, progress check-in, review patient's outcome, adjust plan, analyze preliminary data to measure effectiveness. And on week 8, reinforce and motivate, offer additional educational resources, set up a peer support group to encourage participation. And then on week 9, final data collection, hold final counseling section to sustain progress, collect feedback, and post intervention data. And in week 10, evaluation, wrap up, analyze outcomes, compare with the baseline data, debrief staff on results, and discuss improvement. Prepare a report with a recommendation for long-term adaptation. And from this, there was a lot of feedbacks that we received, which was taken into consideration, and we'll discuss more about that. What was in a statistical form, a statistical way, how we were able to get a better results when it was compared with two modifications with lifestyle as well as anti-obesity management medications. Formation of work played a critical role in obesity management through patient education, counseling, and ongoing monitoring of treatment effectiveness. Advanced practice are uniquely positioned to lead obesity management initiatives by integrating evidence-based practice, coordinating interdisciplinary care, and advocating for system-level changes that improve access to comprehensive obesity treatment. By incorporating evidence-based obesity intervention into routine care, nurses can help improve patient outcome and support long-term weight management along with anti-obesity medications. The methods and design. The project was implemented at the practicum clinical site where I was practicing, where adult patients receive routine healthcare services. Participants included adult patient aged 18 years and older with the BMI of 30 kilograms per m square or higher who presented to the clinic during the project implementation period. A total of 51 adult participants met inclusion criteria were included in the final analysis. The intervention consisted of a structured obesity screening and management protocol implemented over a 10-week period. Several outcome measures were used to evaluate the intervention's effectiveness. Anthropometric measures, including weight, BMI, waist circumference, were used to assess physical changes associated with the intervention. Behavioral outcomes were assessed using the 3-factor eating questionnaire, which evaluates cognitive restraint, uncontrolled eating, and emotional eating. TFEQ is a validated and reliable instrument commonly used to assess eating behaviors in obesity and weight management research. Additional measures included medication adherence records, dietary tracking tools, physical activity monitoring. Data were collected at baseline and at the conclusion of the 10-week intervention period. All data were stored in secure, password-protected electronic files with access limited to authorized project personnel. Findings will be reported in aggregate form to protect patient confidentiality. So moving forward with the sample, we collected samples in both times, pre and post interventions BMI. And in that, descriptive statistics were used to evaluate BMI outcome before and after implementations of the intervention. Mean BMI decreased from 37.26, 5 SD is equal to 5.38 pre-intervention to 34.02 SD equal to 5.29. post-intervention, representing a mean reduction of 3.24 BMI units. That's a good one. That's a very good change in that 10-week period. A paired samples t-test demonstrated that this reduction was statistically significant. T50 is equal to 18.52 p, which was less than 0.001. This finding support the effectiveness of integrating a structured lifestyle with GLP-1 receptor agonist pharmacotherapy to improve the obesity outcome in clinical practice. So we can see it is in, I have put down this in a graphical form, which to make it a little more understandable. So this is how we got the numbers, which we see that it has got good, just showed a very good improvement by the end of 10 weeks. Quality statistical analysis was used, data analysis was used to evaluate changes in BMI as the primary outcome variable. The independent variable in this project was the implementation of GLP-1 receptor therapy combined with lifestyle modification, and the dependent variable was BMI measured over time. The pre-post design allowed each participant to serve as their own control. Descriptive analysis demonstrated improvement in obesity classification over time among both female and male participants. Mean BMI decreased from 37.26 SD equal to 5.38 at baseline to 34.02 SD equal to 5.29 following completion of the 10-week intervention, representing a mean reduction of 3.24 BMI units. The pair samples t-test demonstrated that this reduction was statistically significant. T50 equal to 18.522, which will give us p less than 0.001. The similar standard deviation valued between baseline and post-intervention measurements support the consistency of intervention effect. This findings demonstrated a statistically and clinically significant reduction in BMI over the intervention period and support the effectiveness of combined pharmacological and lifestyle intervention. The magnitude of BMI reduction observed in this project exceeds the clinically recommended threshold of 5 to 10% weight loss, indicating a meaningful reduction in obesity related to health risk. Quality feedback from the staff indicated improved confidence in obesity management, increased consistency in counseling, and enhanced engagement in evidence-based treatment practices. Great job. So here are the results. These are like based on the woman pre-intervention obesity classification and woman post-intervention classification, men pre-intervention obesity classification, and men post-intervention obesity classification. These are divided into class 1, class 2, class 3. Class 1 is BMI between 30 and 34.9. Class 2 is BMI between 35 and 39.9, and class 3 is BMI greater than 40. So we can see that in the first figure, where women pre-1 was, class 1 was 39%, class 2 was 36%, and class 3 was 25%. And when it comes to post, it became 47% in class 1. In class 2, it became 28%, and then class 3 it became 25%. So class 1 itself, it became very good. They were able to reduce it in a greater amount. In the figure 3 in men, pre was like 57 in class 1, class 2 29%, and in class 3 14, and in men class 1 became 67%. And class 3 is 0%, and in class 2, 33%. So you can see the improvement in here, how it changed from the figure 1 to 2, 3 to 4, which shows the difference between the figure 1 to 2 and 3 to 4, uh, which will give us an idea of between when we combine the lifestyle modifications along with the anti-obesity management. The limitations that we had was individuals with mental health issues, limited health literacy, unstable living conditions, or various socioeconomic disadvantages were often left out. The fidelity of behavioral interventions was variable. The lack of transparency, delivery method, provider qualifications, section frequency, adherence monitoring were either briefly mentioned or omitted entirely. The absence of a standardized behavioral protocol, lack of registered dietitians, psychologists, exercise physiologists, and care coordinators, the duration of follow-up, funding, and potential bias. Few studies assess cost effectiveness, insurance-related barriers to pharmacologic treatment. Most studies also lack theoretical framework to guide the design of behavioral compound. Discussion. Substantial evidence support that the implementation of structured lifestyle modification programs combined with pharmacologic therapy for the management of obesity. Clinical guidance consistently emphasized that lifestyle intervention remained the cornerstone of obesity treatment with pharmacologic therapies serving as adjunctive treatment for individuals who meet specific clinical criteria. Lifestyle modification program typically include dietary counseling, increased physical activity, behavioral therapy. These interventions aim to promote sustainable weight loss and reduce obesity-related health risk. Research indicates that comprehensive lifestyle intervention can result in modest but clinically meaningful weight loss when patients receive structured support and follow-up care. More recent research highlights the effectiveness of combining lifestyle interventions with second-generation anti-obesity medications, emphasize the pharmacological treatments such as semaglutide and tirzepatide demonstrate significant weight reduction when used in conjunction with lifestyle modifications. Murphy and Finucane further emphasize a structured lifestyle program remain as an essential component of pharmacological obesity treatment because the behavioral counseling and patient education enhance medical adherence and help patients maintain long-term lifestyle changes. National guidelines also support comprehensive approach to obesity management. Recent evidence support that use of GLP-1 receptor agonists such as semaglutide and tirzepatide in combination with lifestyle modification to improve weight loss outcome beyond those achieved with lifestyle interventions alone. The collective body of evidence supports the implementing structured obesity management program and combined lifestyle counseling, behavioral intervention, and when appropriate, pharmacological therapy. These studies demonstrate strong internal validity and consistent finding across diverse populations. This project highlights several important implications for nursing practice. Advanced practice nurses are uniquely positioned to lead obesity management initiative by integrating evidence-based practice, coordinating interdisciplinary care, and advocating for system-level changes that improve access to comprehensive obesity treatment. From a patient safety prospect, nurses are instrumental in monitoring medication tolerance, identify adverse effects, and reinforcing adherence to lifestyle medication modifications and pharmacologic therapy. In conclusion, based on findings of this QI project, several recommendations can support ongoing improvement and broader improvement. First, healthcare organizations consider adopting standardized obesity management protocol that combine lifestyle modification counseling with appropriate pharmacology theory. Second, continued patient education and follow-up support should be incorporated into the obesity management program. Third, the healthcare leaders should support provider training and continuing education focused on obesity as a chronic disease. Fourth, future research and evaluation are recommended to examine long-term outcome associated with combined this thing. And these are the references, all that.